So good morning, everyone. My name's Kaitlin. I'm one of the PGY3s in the FR Emergency Medicine program here at the University of Ottawa. And my Grand Rounds Liver Let Die hopes to present an approach to splanchnic vein thrombosis and shock liver in the emergency department. So today we're going to link these two seemingly unrelated ideas through a case I saw this past year. And now the reality is that in caring for this patient, I didn't really feel like the all-powerful James Bond. You could say that I had a license to kill, but it wasn't really for good reasons. It was mainly because I had no idea what was going on. Thank you for the laughs. I'm really not funny, but thank you. And I struggled to really recognize the diagnosis. I struggled to recognize how sick the patient was and how sick she could become, what to do next and what consultants to involve. And no matter what I did, the patient seemed to just keep getting worse and worse. So this case really drove me to take a deeper dive into these topics because I think I'm probably not the only one with that same discomfort. So today we're going to talk about splanchnic vein thrombosis, and this basically includes 4 types of thrombi. So portal vein thrombosis, hepatic vein thrombosis, mesenteric, and splenic vein thrombosis. We're going to contrast the current guidelines in managing these conditions. We're going to consider disposition planning and then review some management options for these patients as well. And then we'll talk about some of the complications. So some of the more common ones being bowel ischemia, and then some of the more rare complications such as shock liver. And then we'll touch on shock liver a little bit, touch on overview, identification, and management. So let's start with that very case that inspired my interest in this topic. It's a bit of a journey to go all the way through, but we'll go through it step by step together. So you have a 56-year-old female who presents to your emergency department with upper abdominal pain. She's known for hypertension, dyslipidemia, and peptic ulcer disease, and she actually had a duodenal perforation last year from an ulcer for which she underwent surgical repair. She's since recovered well, great functional baseline, independent from home. She's on enalapril, Lipitor, and hormone replacement therapy for some menopausal symptoms, and she has no known allergies. So you quickly narrow in on your differential being kind of gallbladder, biliary pathology, and you would decide to order an ultrasound as your first-line imaging test to rule these things out. So the ultrasound report returns. They don't identify any gallbladder or biliary tract pathology, but they're wondering if they can maybe see a filling defect of the splenic vein. And they recommend a dedicated Doppler ultrasound or a CT with contrast to further characterize that. So in typical eMERGE fashion, while you're waiting for those further tests, your patient starts to decompensate. So she's developing these episodes of hypotension and she's getting a bit more drowsy. Your CT finally comes back and it confirms that the patient has a splenic vein thrombosis. And I remember thinking to myself, okay, great, I have my diagnosis, I'll consult medicine and I'll be done. But unfortunately, if it was that simple, we wouldn't really need to do a whole grand rounds on it. And as we'll continue to see, this was really only the start of our patient's story. So in recognizing this clot, you consult thrombosis, and with their recommendation, you start the patient on low molecular weight heparin. Unfortunately, the patient's hypotension continues. She's really only transiently responding to fluids, and you end up having to start her on a low-dose norepi infusion, and you consult the ICU. So for a few moments, let's take a step away from this case. So we know what our diagnosis is, a splenic vein thrombus, but what does that really mean? So when I think of abdominal vasculature anatomy, my mind kind of pictures something like this, which is not so helpful. But in reality, it looks a lot. So we're going to be talking about splanchnic vein thrombosis, and as I alluded to already, this basically includes 4 different types of thrombi. So let's review the anatomy. So there's a bunch of veins that drain the upper abdomen. And I like to think of these as basically 2 Y junctions. So first, you have your splenic vein, which drains the spleen. And this joins with the inferior mesenteric vein, which drains the left colon in this first Y junction on the right of your screen. Then you have the superior mesenteric vein. And this drains the right colon and comes up and joins with that previous combination to form the portal vein, which drains into the liver. At the top of the screen, you have your hepatic vein, which, as it sounds, drains out of the liver. Now, as we alluded to again, there's 4 main types of thrombi that are included under this overall subheading of splanchnic vein thrombi. So first being splenic vein thrombi. Next, mesenteric vein thrombosis. So this includes either a clot in the superior mesenteric or the inferior mesenteric vein. You could also have a clot in your portal vein, and that's one of the ones we've all heard of. It's the most common form of splanchnic vein thrombosis. And then you could have a hepatic vein thrombosis. That's the most rare form of splanchnic vein thrombosis. Many of you may have also heard of this referred to as Budd-Chiari syndrome, and that's technically true. Budd-Chiari syndrome is an overarching syndrome. It includes any sort of hepatic vein outflow obstruction. So most commonly, this is from a clot, so a hepatic vein thrombus. But as you can imagine, you could also have external compression on that hepatic vein. So something like a cancer, especially like a hepatocellular carcinoma, compressing that hepatic vein and causing outflow obstruction. For the purposes of today's talk, when we talk about Budd-Chiari syndrome, we're only going to be talking about it as it relates to a hepatic vein thrombus, and that's the treatment that we'll be talking about. Obviously, if there's a cancer involved, the treatment's a little bit different. And the reality is you could not know any of this anatomy, and it wouldn't really matter, because for the most part, these patients have similar risk factors, they present very similarly, the diagnosis is very similar, and as is the treatment. And a thrombus in any of these areas is bad because it ultimately leads to congestion and backflow, which increases bowel edema and decreases arterial inflow into the bowel, which can result in bowel ischemia. So there's a huge spectrum, unfortunately, in how these patients can present. They can be all the way from asymptomatic, where many of these findings are just incidental on their imaging, to presenting all the way to peritonitis and having bowel ischemia. And then there's those patients that tend to present more in the middle. So patients tend to complain of abdominal pain, if they do have symptoms, and they'll often have some other non-specific symptoms like nausea, vomiting. On exam, they may have a completely benign belly exam, or they may have a bit of abdominal distension, either from preceding liver disease and the ascites they have, or because they're starting to develop some bowel congestion, and this can result in an ileus. In patients with preceding liver disease, you're more likely to see them present with a GI bleed. And presentations of splanchnic vein thrombosis can either be acute, in which you're more likely to develop symptoms because you lack those collateral veins feeding the area, or they can present quite chronically, in which these patients often will never see an emerge because they don't have those symptoms. They've got the collaterals that are preventing the development of symptoms. And for today, our presentation will really just focus in on those acute presentations. As I alluded to, that's what we're more likely to see and emerge. And that's where the treatment guidelines are really much more clear for these patients. So let's talk a bit about incidence. When I said that this was my topic, everyone was like, what the heck? Like, do we even see these? Do these even exist? But approximately 4,320 Canadians per year are diagnosed with a splanchnic vein thrombosis. So while these conditions are rare, I think it's important that we put them into a bit of perspective. So PE and DVT diagnoses occur in about 108,000 Canadians per year. That's roughly 25 times as common as a splanchnic vein thrombosis. And so accordingly we in the Emerge have become really experts at looking for these diagnoses, independently managing them without having to call thrombosis at all. And while we'd never be expected to expertly manage a splanchnic vein thrombosis without our thrombosis colleagues, I think it is really important that we know when to go looking for it. One of the things we're always taught as Emerge docs is that for any condition that has a high chance of morbidity or mortality, it's really important that we look out for it, no matter how rare it is. Think about how often aortic dissection, cauda equina syndrome are on your differential. You think about them every single shift, and you order a ton of negative tests to try and rule these things out. But when you actually put these things into perspective, you can see that a splanchnic vein thrombosis is actually far more common than those other diagnoses that you think about every single shift. All of these diagnoses carry a high risk of morbidity and mortality if they're missed. And what it really speaks to is that in the correct patient, we need to be including a splanchnic vein thrombosis on our differential so that we don't forget to rule it out. So what really is that correct patient? So when you Google a list of risk factors for these conditions, sometimes it can be overwhelming, the list that UpToDate will spew out. But I want to basically bring it back all down to what the root of the cause is. So any form of clot tends to result from one of three parts of Virchow's triad. People may have risk factors in one category or multiple, but all it really takes is one. So remember that Virchow's triad refers to stasis or stagnant blood flow, hypercoagulability, or any sort of endothelial or vascular wall injury. So starting with stasis, so the main causes of sluggish blood flow that tend to lead to someone to develop a splanchnic vein thrombosis are cirrhosis. So if you can imagine a big cirrhotic nodular liver kind of compressing down on the veins as the veins are trying to feed through the liver, that blood's probably not flowing so well. Same with CHF, these patients get backflow into the liver, congestive hepatopathy, and again, blood is flowing slowly and predisposed to forming clots. Then I want you to think about anything that causes abdominal inflammation within the belly. So this can be infection. So infection near the site of all these vessels. So a liver abscess, pancreatitis, cholecystitis. But there are many cases of diverticulitis all the way in your left lower quadrant, leading to inflammation within the bowel and causing these clots. I also want you to think of surgery like our patient had. So roughly surgeries in the last year are more at risk, but surgeries leave a bunch of resulting inflammation in the bowel and increases your risk of clotting. Any patients with IBD, especially if they're during a flare, and any form of trauma or connective tissue disease, so vasculitis, think about lupus, think about scleroderma, these all increase the risk of clotting as well. And then your last main group of risk factors is that hypercoagulability piece. So any patient who's predisposed to forming thrombus. So any cancer patient, and this can be any cancer. It's most common in your abdominal malignancies, and especially in that HCC cancer, which is right next to all of these vessels, but it can occur with any cancer. Any sort of thrombotic condition, and we think of mainly the ones that are at risk for forming splanchnic vein thrombosis being your myeloproliferative neoplasms, so things like essential thrombocytosis, things like polycythemia vera. You should also think about this in other clotting conditions, so factor V Leiden, paroxysmal nocturnal hemoglobinuria. These are all factors that predispose the patient to form clots. And sometimes it's just a matter of being pregnant or having some extra hormones on board, whether that's hormone replacement therapy in our patient or being on birth control. So in terms of blood work investigations that these patients require, if the splanchnic vein thrombosis results in bowel ischemia, as you've learned to recognize, you'll often see high white count, you'll see hemoconcentration, an elevated lactate, and a low pH. And if they have underlying concomitant cirrhosis that's predisposed them to causing this condition, you'll often see those elevated liver function tests, so Billy, INR, they may have a high creatinine as well, and they're often quite thrombocytopenic. Now, the challenge with this diagnosis as well, I've alluded to a few, kind of broad presentation, don't see it all that commonly, or at least we perceive we don't see it all that commonly. But the other challenge is that on blood work, you might just see normal or only mildly elevated liver enzymes. And that's because when you think about the liver's blood supply, it's getting 2/3 of its blood supply from the portal vein, and that other third of its blood supply is coming from the hepatic artery. So even if you have a clot in your portal vein, in your splenic vein, in your mesenteric vein, that's causing decreased relative blood flow to the liver is still getting 1/3 of its perfusion from the hepatic artery, and so it's not really showing any signs of ischemia, and those those liver enzymes are not getting raised. Where you're most likely to see elevated liver enzymes is in that hepatic vein thrombosis, so Budd-Chiari syndrome. So here, if you have complete obstruction of that hepatic vein, there's no other vessel that can help drain the liver, and all that backup causes poor perfusion to the liver, and you'll often see liver enzyme elevations in the thousands for these Budd-Chiari patients. So I think we're all pretty good at Emerge about having a broad differential when it comes to our thousands club. We think commonly of the toxins that cause this, so Tylenol, our viral hepatitis causes, our autoimmune causes, metabolic disorders, HELP syndrome. But what I want us to be adding to our differential as well is that Budd-Chiari syndrome, or that hepatic vein thrombus, and shock liver, which we're going to get into a little bit later. But these should be on every thousands club differential going forward as well. And then what about imaging investigations for these patients? So really, ultrasound is widely considered first line when you're looking for a splanchnic vein thrombus, and you'll see or the techs and the radiologist will see a filling defect in that vessel, and often a non-compressible vessel due to the clot. It's best seen with Doppler studies, but sometimes they can get an idea of it even without a Doppler. And there's a wide number of guidelines that really go over the diagnosis and management of splanchnic vein thrombosis. Thrombosis Canada has a guideline, the European Association of the Study of Liver Disease has a guideline, and there's 2 American guidelines, the American Association for the Study of Liver Disease and the American College of Gastroenterology. And universally, they all recommend ultrasound as the first-line imaging test in these splanchnic vein thrombosis patients. However, we are in a world where splanchnic vein thrombosis is not the only thing on our differential, and I definitely recognize that. And therefore, sometimes it's going to be completely appropriate that we go looking for this with a CT, and the guidelines also support that that's a great test to go looking for this. CT is great, always done with contrast so you can see those vessels, and it's great when you have a broader differential, when the patient's older, if you have a higher BMI where ultrasound might not be able to get a great look at those vessels. And CT is great for a few other reasons too. It can really show us the extent of the thrombus. So sometimes this clot may start in the splenic vein, but it can extend without treatment into some of the other veins we've talked about. It can show us if there's any complications of bowel ischemia. And it can show us if there's a focus of infection. So does this patient also have diverticulitis or cholecystitis that's gone on to cause this splenic vein thrombus? So studies have shown that 2% of all abdominal CTs have a splenic vein thrombosis on it. Think about how many CTs you guys order. I mean, for me, it's at least one a shift, maybe 2 or 3, which means that for every 1 in 50 scans we're ordering, we should be seeing a splenic vein thrombus on it. I personally am not, which either means it's not getting reported or I'm not looking for it. And I don't have the answer to that yet for you. 10 years ago, this disease was widely under-recognized, understudied, underreported, and we didn't actually treat any incidental findings of splenic vein thrombosis. But over the past 10 years, we've learned that anticoagulation treatment for both asymptomatic and symptomatic patients widely improves outcomes, and that any patients where this diagnosis is found should be treated. So let's get back into our case. So remember, we have a 56-year-old lady who's been diagnosed with a splenic vein thrombus. We started her on heparin under the advice of thrombosis, and she's in the ICU because she's unfortunately requiring low-dose pressors. Unfortunately, over the next hour, the patient develops gradually worsening hypotension. She's now on multiple pressors, and her mental status has progressed to the point that she's requiring intubation. This was one of the first cases of splenic vein thrombosis I had ever seen, and I missed it initially because I wasn't thinking of it. So I did include radiology into the fact that I was looking for it. And to be honest, I didn't even really know when I should go looking for it. So when do the experts say that we should be having splenic vein thrombosis on our differential? So I asked an expert, so a friend and colleague, Dr. Caleb Rhoda, who's a GI fellow out of UBC, but he did his core medicine training here at Ottawa. So he said that we should be considering splenic vein thrombosis in any patient who has abdominal pain and or elevated liver enzymes, especially if they're up in the thousands, when they have one or more of the following. So thrombophilia, underlying cancer, or cirrhosis. And especially if that patient is presenting with signs of decompensated cirrhosis and worsening portal hypertension, so worsening ascites or GI bleeding. So this is my 001 take home for you today, which is that I want you to include splenic vein thrombosis in your differential. We inaccurately perceive this diagnosis as extremely rare, but as we've gone over, it's really not as rare as we think, and it's an emerging diagnosis. If we don't include it in our differential, we'll never go looking for it and we won't find it. So getting back into our case, recall that I really narrowed in on that upper abdominal pain presentation in a relatively young patient to being gallbladder or biliary related. So radiology appropriately protocoled the study as a limited ultrasound of the gallbladder. So how then did they even see this query filling defect? Did I just get lucky? I wasn't even looking for one. So I asked another expert, so Dr. Bilal Karni, he's a senior radiology resident here at TOH, and he educated me that pretty much every limited ultrasound we're doing of the gallbladder here at TOH is also assessing all of these veins that we've talked about. If the tech sees any sort of abnormality, the vein's not compressible, they'll throw some Doppler on there and try to see if there's a filling defect. And if there's an abnormality, it'll get reported. That being said, if there's no abnormality and things look fine, you won't even see it listed in the report, and you might have never even known that they looked for this. The problem, though, is that this is very operator dependent. While the majority of techs are doing this full exam, even in a limited study, they're not technically required to, and it's not always getting done. So we, if we're thinking about this diagnosis, need to be writing it in our rec so that radiology and the techs know to go looking at those veins very closely. And that's really the only thing I'm asking you to change about your practice. I don't need you to be ordering Doppler ultrasounds in every patient that probably just has a cholecystitis, but I do need you to be writing it on the rec when it's a consideration to you so that it's properly looked at by the techs. So we know when to think of this diagnosis, and we know how to diagnose it. But how do we manage it? And as I've started to allude to already, really the first line management option in these patients is anticoagulation. Anticoagulation, often with heparin, really prevents extension of the clot. It restores venous patency and recanalizes that vessel. And in turn, this helps to decompress the bowel to prevent ischemia and to decompress the liver to prevent liver dysfunction. So anticoagulation is first line treatment based on all four of the guidelines we've talked about already, as well as from the International Society on Thrombosis and Hemostasis, most recent guideline. Unfortunately, though, due to patient comorbidities and the heterogeneity of this disease, as we've talked about already, rarely is treatment all that simple. There's a number of considerations that we need to be thinking about, and of course, we're not alone in making these decisions. We're lucky here that we always have thrombosis, and we can talk to them about these patients, and they can help guide us in our treatment. But we need to know what kinds of information thrombosis wants to hear about so that they can provide their anticoagulation plan. So your 002 take-home is that anticoagulation with low molecular weight heparin is first-line treatment in any splanchnic vein thrombosis. Again, when it's not an emergency situation, there is totally time for us to be talking with thrombosis about these patients before starting them on heparin. One of the biggest risk factors for splanchnic vein thrombosis, as we've alluded to, is cirrhosis. But unfortunately, cirrhosis impacts both procoagulant and anticoagulant processes within the body, and it's actually considered an independent risk factor for bleeding and for clotting, which makes things complicated. Considering this fine balance, there have been a number of studies that have looked into the safety of anticoagulation for splanchnic vein thrombosis in patients who have underlying cirrhosis. So this is a systemic review and meta-analysis done in 2021, and it demonstrated that in both cirrhotic and in non-cirrhotic patients, anticoagulation is safe and recommended. It reduces the risk of thrombus progression, and it paradoxically actually decreases the rates of major bleeding in these patients, which I found hard to wrap my head around. But if you remove that clot in the portal vein, you're actually decreasing this patient's portal hypertension. More clot means more hypertension because less flow. And so over the long term, you're actually decreasing their rates of representing with major variceal bleeds. So all guidelines, again, support that anticoagulation is safe in cirrhotic patients and in patients with cirrhotic complications like portal hypertension. So what do our thrombosis experts at TOH think? So I spoke to Dr. Carrier, who's one of our thrombosis experts here, and as he alluded to, anticoagulation is rarely an immediate decision unless these patients are acutely and critically unwell. So therefore, when thrombosis hears about these patients, especially the ones with underlying cirrhosis, they'll often involve GI in the conversation and have a discussion about what this patient's status is. Are they known to be thrombocytopenic? Have they had previous variceal screening? Are they at risk of having undiagnosed varices? And should we go have a look with a scope first, band anything that's there before we start them on anticoagulation? And that's why it's really best for us in the eMERGE to be engaging thrombosis in that decision. We don't need to make this decision all ourselves, but it is really helpful when we're on the phone with them to give them that information what they're looking for. They're known to GI, they've had screening, or this is a new diagnosis of cirrhosis. We don't know if they have varices and what are their platelets like, and so on. And our thrombosis colleagues will guide us through this discussion over the phone, but just helpful to know some of the information they might be asking for. So this largely fits with our current practice. About 81% of us said that they would discuss this case of hepatic vein thrombus with thrombosis prior to anticoagulating them and admitting them to medicine. So this is our 003 take-home. So anticoagulation in splanchnic vein thrombosis is safe in cirrhotic patients and in those with portal hypertension complications. And this complicated paradox of both the risk of clotting and the risk of bleeding in cirrhosis has prompted further studies that have really looked into whether or not we should prophylactically anticoagulate these cirrhotic patients. If they're so at risk of forming these clots, should they be on lifelong anticoagulation, or is that too unsafe because they're also at risk of bleeding? It's a challenging question. And this RCT by Villa et al. In 2012 found that prophylaxis with heparin in cirrhotic patients actually decreased the rates of developing portal vein thrombus and therefore decreased the rates of developing hepatic encephalopathy and ultimately liver failure. Of course, more data is needed before implementing this strategy. And when I spoke to Caleb, he was saying pretty much across Canada, this is not routine standard of practice. Cirrhotics are not prophylactically anticoagulated for these splanchnic vein thrombi, but maybe in the future. As I said, it's an emerging diagnosis. So we know that heparin is first line, but what about DOACs? We use these all the time in other venous thromboemboli like PE and DVT. So is there any evidence they also work in treating splanchnic vein thrombi? So in speaking with Dr. Carrier and the thrombosis team here at TOH, they do use DOACs to treat their splanchnic vein thrombosis patients. And the evidence for DOACs is largely based on this 2022 prospective study that Ottawa actually took part in. So it showed that DOACs are a safe treatment alternative to what was currently standard of care at the time, warfarin, in long-term management of these splanchnic vein thrombi patients. So if thrombosis is using DOACs, then the question becomes, could we not just discharge someone home from the emerge whose pain is well controlled or is otherwise asymptomatic if this was an incidental finding, put them on a DOAC and get them to see thrombosis urgently as an outpatient? I asked Dr. Carrier this, and I wanted to see where our group practice was. 25% of us felt that we would send this patient whose pain was well controlled, who was clinically stable with their portal vein thrombus, for an outpatient thrombosis consult. And Dr. Carrier really cautioned against discharging these asymptomatic or well-controlled pain patients from the ED without speaking with them first. They will rarely ever send these patients home. Often, always, they require an inpatient approach, and this is for multiple reasons. So DOACs, as we've stressed upon already, are not initial management. Always, these patients should be started on heparin because this allows us to change the anticoagulation strategy as the case evolves. Maybe they'll go on to need surgery, maybe they'll go on to need scopes, maybe they'll develop bowel ischemia. And as I alluded to already, often these patients require a multidisciplinary approach between GI and thrombosis, which is best accomplished after they're admitted as an inpatient. Further, as we'll learn about shortly, patients with splanchnic vein thrombosis, as I mentioned, are at risk of developing these complications like bowel ischemia. And so they really require a period of monitoring and should not be sent home. So this is our 004 take-home. Splanchnic vein thrombosis patients require inpatient management and a multidisciplinary approach, often between thrombosis and our GI colleagues. Okay, so according to thrombosis and to GI, these patients need to be admitted. But as we know, they don't admit patients themselves. And this is not a TOH problem. It's pretty universal across multiple centers that GI and thrombosis don't always have admitting privileges. So where do these patients go? There's really no guidance in the admission algorithms as to where these patients should be admitted in hospital. So let's see what our group practice is. There's quite a bit of controversy for this mesenteric vein thrombus. About 60% of you would consult medicine and ask them to admit, 25% thought about calling general surgery, and 15% called vascular surgery. The reality is that most of these splanchnic vein thrombosis patients can be safely managed by medicine, except when there's concern for or high risk of developing bowel ischemia. So when do we worry about that? All of the guidelines we've talked about so far really emphasize that in every single case of splanchnic vein thrombosis, we need to be considering that they could progress to bowel ischemia and ruling it out. So now, as we know from previously, the splenic vein drains the spleen, the hepatic vein drains the liver. Sounds kind of named as they sound, or named as they do, I should say. And so therefore, the highest risk for bowel ischemia is not really here. These structures aren't draining the bowel. But on the other hand, when we think about the mesenteric vein area, these veins are directly draining colon. And so as soon as you form a clot here, it takes very little time without anticoagulation for you to start getting backflow, bowel edema, and bowel ischemia. There is also some risk of bowel ischemia with portal vein thrombi, as again, that vein is still draining the colon. It's just more anatomically far removed, if you will. So it just takes longer time to develop bowel ischemia in those portal vein thrombus cases. So how do we actually assess for bowel ischemia? So the guidelines recommend that we consider it in any patient who's having progression of their pain despite being on anticoagulation. And like I said, that can be tough because it's really a spectrum. Sometimes these patients will have peritonitis from bowel ischemia, whereas other times they present a lot more similarly to our mesenteric ischemic patients with an SMA clot, where they just have a benign-ish abdomen, but their pain is really out of proportion. We should also be considering bowel ischemia in any patient who's having rectal bleeding, who's febrile, who's having ascites or multi-organ dysfunction. And then on lab work, we're looking for that leukocytosis, that elevated lactate, and that acidosis. And really our best prevention against bowel ischemia is early treatment with anticoagulation. So this brings us to our 005 take-home, which is that bowel ischemia should be ruled out in any patient with splanchnic vein thrombosis. And we'll talk a little bit about how we can decide that we've ruled it out appropriately, depending on the case. So I spoke to a good friend of mine, a senior surgical resident here at TOH, Dr. Mojgan Rezaifer, And she wanted me to pass along that any sort of clot that's larger and more occlusive is, of course, more at risk for developing bowel ischemia. Often these components are written on the CT report, but again, not always. And if it's an ultrasound, you may not know that piece. She said that a general surgery consult in the emergency department is reasonable for any mesenteric vein thrombi because of that high risk of progressing to bowel ischemia. And she again recommended that for assessing for bowel ischemia, we should be doing this with a lactate, a pH, our clinical exam, and then a CT abdomen with contrast. And that's our 006 take home for today. Mesenteric vein thrombosis is highest risk for bowel ischemia, and any patient where you're finding a mesenteric vein thrombus warrants a general surgery consult in the emergency department. So I want to bring it all back for us here, and this is kind of my approach to dispositioning these patients. So up at the top, you're going to start by finding your diagnosis. You're going to discuss every one of these cases with thrombosis, and as I mentioned, it's really a case-by-case decision. Very, very rarely will they ever recommend outpatient follow-up, but in some cases they may, and that's for them to decide. But the overwhelming majority of these cases are going to need to come into hospital. So then you need to find out where to admit them to hospital. So for any portal, hepatic, or splenic vein thrombosis, we still need to be considering bowel ischemia. And I kind of think of this as like an initial screen. So I'm looking at my blood work. Is their pH normal? Is their lactate normal? Am I reassured by the lack of peritonitis on their exam or their lack of degree of pain? And then I would only obtain a CT abdomen if I don't have one already, if I'm concerned by one of those features on my screen. If that screen is negative, I'm not concerned about bowel ischemia, then these portal, hepatic, and splenic vein thrombi can be safely dispositioned to medicine. And they'll be happy to see these patients, continue them on the heparin, and involve thrombosis GI as needed as an inpatient. But I suggested a different approach for mesenteric vein thrombosis. And again, that's because of that high risk for already having or for developing bowel ischemia because of their proximity to the bowel they drain. If not already diagnosed on CT, any patient with a mesenteric vein thrombosis needs a CT to rule out bowel ischemia. Even if that CT does not show any evidence of bowel ischemia, I would still consult general surgery in the emergency department because of their high risk of developing bowel ischemia. General surgery may be non-concerned and they can talk to medicine as needed, but every general surgeon, resident or staff we've been able to talk to throughout this would be happy to see this consult again because of that risk. Okay, so let's jump back into our case. So as we remember, we have a patient with a splenic vein thrombosis who's on pressors and intubated in the ICU. We really thought we might be missing bowel ischemia in her. Why else was she getting so sick? But her repeat CT scans didn't show any evidence of this. So what then were we missing? Why was she not getting better despite anticoagulation? As we've heard, anticoagulation is always first line in these splenic vein thrombosis cases, but sometimes it's not enough. Sometimes we need, it's not possible, and sometimes it's not working. So our patient, unfortunately, after being on heparin for a few hours, developed an INR in the 20s. And in discussion with thrombosis, they actually recommended stopping the heparin because now her bleeding risk had become too high. So what other treatments are available? So thrombosis recommended that we talk to interventional radiology to see if they would ever consider something like thrombolysis, so local clot busting with TPA or streptokinase. And we chatted with them, and given that heparin was no longer an option, and reviewing the entire patient case, she wasn't actually a candidate. Her INR was just too high, and IR was too worried that she was going to bleed throughout the procedure. So here's the basic management escalation recommendation based on guidelines in all of these cases of splenic vein thrombosis. So as I've alluded to several times, anticoagulation is always the first line treatment in these thrombosis cases. And if anticoagulation is not working, then patients may be considered for either a thrombolysis or an angioplasty or stenting procedure. Most commonly, what you're going to see done is thrombolysis in these cases, and this is done here at TOH by interventional radiology. And I point that out only because even at the time going through the case, we weren't sure if vascular surgery did it, IR did it, but it is IR here at TOH. Sometimes this still doesn't work, and patients have to go on to receive what's called a TIPS procedure, or a transjugular intrahepatic portosystemic shunt, which basically just forms a bridge or a connection between that portal vein and the hepatic vein to really offload the congestion of the liver. This is also done here at TOH by IR, despite not being a center that offers liver transplants. And unfortunately, sometimes patients still progress after their TIPS procedures and need to go on to Toronto to have a liver transplant. Now, I want to emphasize that really the main case where you're going to see a patient progress through all of these different escalation strategies is in a Budd-Chiari syndrome. And I also want to stress that we in eMERGE, really our only role is anticoagulation or no anticoagulation. And even for thrombosis, or even for us, we have thrombosis to help us with that decision. But I do think it's important to be aware of what the other escalation strategies are so that we can recognize when a patient's not responding the way we would expect or getting better on anticoagulation and involve other consultants as necessary, and so that we can counsel our patients on what they should expect. So going back to our case, unfortunately, as we remember, we're unable to keep anticoagulating her clot because of her profound elevated INR, and thrombolysis is not an option because of her bleeding risk. So next, on repeat blood work, the patient's transaminases start to rise, and she's now developing AST and ALT in the thousands. And you recognize that she's starting to develop shock liver. Over the next several hours, she undergoes this worsening cycle of acidosis, coagulopathy, and hypotension, and she eventually dies. And now shock liver is a very rare complication from splanchnic vein thrombus, but I think it brings up some important things that I want to allude to that we should be aware of here in the emergency department. So let's talk a bit about shock liver. So shock liver, it's also called ischemic hepatitis, and this is really the preferred name for the condition because as many as 50% of these patients will never have had shock and don't currently have shock. Shock liver, of course, is a more catchy name, and so it's kind of stuck, but ischemic hepatitis is really what we should be calling it. And ischemic hepatitis and shock liver basically refers to this diffuse liver injury resulting from hypoperfusion because of either backlog and congestion into the liver or poor forward flow and perfusion into the liver. And as we've already seen, the liver has this very complex vascular supply, and it's also very metabolically active, and so it's very prone to vulnerability in any sort of perfusion disturbance. As many as 2 to 10% of ICU patients will go on to develop shock liver. So how does shock liver actually occur? So the liver receives 25% of cardiac output from the heart, and under signs of systemic stress, that cardiac output often can't ramp up enough to supply all the demands of critical organs in the body. And this leads to compensation. So oftentimes you'll get vasoconstriction of blood flow to the periphery and to your splanchnic veins, and you'll get preserved blood flow to the brain. Ultimately, this splanchnic vasoconstriction leads to decreased blood flow to the liver and relative hepatic hypoxia to the tissues. And unfortunately, like with splanchnic vein thrombosis, shock liver can also present on a very large spectrum. Patients can either be asymptomatic from it, or they can have very non-specific symptoms like nausea, vomiting, right upper quadrant pain, anorexia, malaise. In terms of the investigations to note, it's important to recognize shock liver, or at least have it on your differential, again, anytime that AST and ALT jump into the thousands. And an important distinguishing factor here is that shock liver is not the same as acute liver failure. So these two clinical entities essentially exist on a spectrum, and it's really important to be able to distinguish the two. So the European Liver Association guidelines describe shock liver purely as elevated transaminases, so AST, ALT in the thousands. When a patient progresses to having encephalopathy, coagulopathy, actual liver dysfunction, this is when we go on to call this acute liver failure. And as in reality, as I'm sure you can probably imagine, it's really rarely that black and white. Lots of these patients are intubated, so assessing for encephalopathy can be really challenging, and serum ammonia levels are rarely that helpful. And similarly with the coagulopathy piece, lots of these patients are very multi-comorbid. They're already on anticoagulation at baseline, or we've started them on anticoagulation for another reason. And they may have preceding liver dysfunction as well. And so recognizing when they've actually gone into this coagulopathic state with liver dysfunction can be challenging. And this was hard for me as a trainee and throughout this case, because oftentimes we're talking about shock liver in the ICU, and we go and look at their coags, and they're wildly elevated. And one thing that I've had to really drive home for myself and want to drive home for you guys is that when we're saying that this is a case of shock liver in that case, It's because we truly believe that the liver function itself is preserved and that the coagulopathy is secondary to other causes. Even when you think about the case that we talked about today, she was profoundly coagulopathic. And yet every consultant I talked about, we referred to this as shock liver. And until doing this presentation, I still thought that she died from shock liver, but that's obviously not the case. She's most likely, the working theory is that she died from fulminant liver failure with an INR in the 20s. Again, a very rare presentation for this thrombus to go on to cause shock liver that causes acute liver failure, but I think it's good to drive the point home. So what about management of shock liver? There's unfortunately really no specific therapy. It's usually self-limited in the absence of ongoing perfusional disturbances. So how do we fix those perfusion disturbances? So really the goals are just to treat those underlying causes. So if they're hypotensive from infection, from hemorrhage, from cardiogenic shock, we treat those things and we try to restore that cardiac output and restore adequate perfusion. Norepi is usually our pressor of choice in these patients as they tend to have quite distributive vasoplesic shock. And so Norepi is really the pressor that we'd like to use best. We also want to avoid any sort of aggressive diuresis in these patients. And unfortunately, there's really no specific therapies to help reduce the risk of reperfusion injury to the liver. As soon as you're seeing a patient with shock liver, it's important to identify that their mortality is upwards of 25%, so quite high. And while I said this is often self-limited with the right kinds of treatments, these patients still are very critically ill. They're much more at risk of dying if they already have concomitant liver cirrhosis, because they're more at risk of going into that acute liver failure presentation. So that brings us to our last 007 take home for today, which is that we should be identifying patients with biochemistry concerning for shock liver, and we in the eMERGE should be initiating appropriate supportive management. And this largely fits with what we're already doing. 95% of us on our survey believe that this was our role in both identifying shock liver and starting supportive management, which is basically just the resuscitative care we're already providing in the ED. But my question was, are there any other treatments we should be doing in the eMERGE for these shock liver patients? So what about something like N-acetylcysteine or NAC? So we know that in ischemic hepatitis, there is this hypoxia of the hepatic tissues, which creates reactive oxygen species. And we know from other areas of medicine that NAC is this potent antioxidant, and it's thought to have a role in maybe treating non-Tylenol related liver injury. There's several randomized control trials out there that support the use of NAC in non-acetaminophen-related acute liver failure. But based on how NAC works, there's a theory that it actually might help earlier on. What if we could give NAC to prevent the development of shock liver or prevent the development from shock liver to acute liver failure? There is limited evidence for this, but it really only comes from case reports. And so I asked an expert, Dr. Hendon, or our very own Ariel, about whether she uses NAC and how she uses NAC. And she recommends using NAC for acute liver failure regardless of the cause. So it doesn't have to be acute liver failure from Tylenol. We know that we can improve these patients' outcomes with NAC in these cases. She feels that there's not currently enough evidence for the use of NAC in preventing the development of ischemic hepatitis or in preventing ischemic hepatitis from developing into acute shock liver. And so she doesn't recommend its use in these patients. And Ariel also agrees it's really practically not our role in the eMERGE to be giving NAC for cases outside of mainly Tylenol. We can happily leave this to our ICU colleagues. Therefore, our role again is in identifying and managing shock liver with resuscitative care and ordering the appropriate LFTs to diagnose this condition. So just to review our take-homes. So number one, I think it's really important that we include splanchnic vein thrombosis in your differential. If you aren't thinking about it in the right clinical context, you will miss these cases, and they're much more common than we think. So that right clinical context, again, is any patient with abdominal pain and or elevated liver enzymes who has one or more risk factors. And the risk factors I really want to drive home are any case of thrombophilia, any sort of cancer, or underlying liver cirrhosis. Again, especially if they're presenting with decompensated liver cirrhosis, so worsening ascites or bleeding. Take home number two is that anticoagulation with low molecular weight heparin is always first line in these patients. But again, it's very reasonable to talk to thrombosis, and they actually encourage us to talk to them in these cases because it's still quite a new and emerging diagnosis. We know that anticoagulation is safe in cirrhotics and in patients with complications of cirrhosis, such as portal hypertension. But again, it's always a matter of kind of making sure that we're doing this as safely as possibly and prophylactically treating any sort of risk they may have for bleeding. And that's why splanchnic vein thrombosis, majority of the time, requires an inpatient multidisciplinary approach. Number 5 is that we should be ruling out and thinking about bowel ischemia in every single splanchnic vein thrombosis case that we see. And we should remember that mesenteric vein thrombosis is the highest risk for developing bowel ischemia, and these patients should get a general surgery consult in the emergency department. Lastly, it's important for us to be identifying patients with biochemistry that's concerning for shock liver and initiating appropriate supportive management. So I'd just like to thank everyone that helped me create this presentation. So Dr. Nick Costain, my supervisor, Deb, Jim, and Warren for being great mentors. My R3 cohort, even though your idea of James Bond starts and ends with Daniel Craig, which is really disappointing to me. And my partner, Dr. Mitch Nicholas, who is probably our local primary care expert on splanchnic vein thrombosis after listening to this talk on repeat for the past 2 weeks. And my pup Luna for all the emotional support during creating this presentation. And a huge thank you to my experts as well, Dr. Rhoda in GI, Dr. Carney in RADS, Dr. Carrier in thrombosis, Dr. Rezaifer in gen surg, and Dr. Hendon here in Emerge and ICU. And a big thank you to all of you guys for taking the time to listen. For this question, anyone that didn't suggest license to kill is wrong for obvious reasons, and I'm not going to go through it further. And these are my references here. Feel free to take any questions if there are any.